discussion a little bit. Uh, Last time I think we started doing the discussion on surgical jaundice, and this is very important topic actually because you will consider yourself lucky if you get a question or a long case or a SEQ because these are common topic and everybody should be ready with most of the answers. Let's move on. Uh, as we discussed last time, if it's an adult, the working diagnosis should run through your mind as soon as you see the yellow eyes of a patient or the history is given as yellow discoloration of eyes. Uh, it could be progressive or short onset. Whatever it is, ultimately the diagnosis and the management will get concentrated on this working diagnosis. So always the common things are common. So you start with bile duct stones, choledocholithiasis, then move on to more malignant causes like head of the pancreas cancer and periampule cancer. You know there's a slight difference between these two. And cholangiocarcinoma and biliary strictures. And this cholangiocarcinoma will come under malignant strictures. And biliary strictures, benign strictures, are generally post-surgical or sometimes multiple passage of stones can cause strictures. And chronic pancreatitis is not a very common cause of jaundice, but again, when you are considering the differential diagnosis, you have to think of that. So your history taking and the discussion will be on some focus questions to identify these causes. And portapetis nodes, again, you should not forget portapetis node as a malignant cause because generally metastatic cancers, upper GI metastatic cancers can give rise to jaundice through portapetis nodes. Commonly asked questions during vivas is that can liver metastases cause jaundice? The answer will be that multiple liver metastases in both lobes generally will not give rise to jaundice because to drop the hepatic function to a level of developing jaundice, as you all know, a large amount of liver has to be replaced by the tumor. So by that time, patient is no more. So general reason is that if there are portapetis nodes or a large secondary deposit close to the uh, liver hilum or portapetis. This MCQ we have done already about the uh, relatively rare causes of jaundice, and we have gone through that during the last discussion. So you all have already gone through it, so I'll just run through it. And when it comes to long case, uh, we have lined up, I have lined up these questions. Generally, we look for, if it is even if it is a observed history taking in exams like ERPM or other universities where the long case is the standard long case. History marking scheme, these points will be looked for. So I think if you've got a jaundice patient, you make sure that in your history, standard history, especially in the middle part of it, where you have taken the story and then now when you are moving on to the focused history or direct questioning part, these questions are there. Because all these direct questions have some sort of importance, like in all the other long cases, they have an importance because that those questions pinpoint towards a diagnosis. May not be 100%, but suggest a part of differential diagnosis. So first thing is the nature of jaundice, progressive or intermittent. Progressive jaundice is generally due to progressive obstruction due to pancreatic head cancers. And intermittent jaundice is traditionally thought to be due to periampullary carcinomas. And because sloughing and regrowth of the tumor is well known, because it's different from CA pancreas when it comes to prognosis and the behavior. And also, what is not mentioned here is intermittent passage of stones. You can get biliary colics, intermittent passage of stones through the common bile duct, giving rise to intermittent jaundice. So that's another cause. And even in a long question, SCQ, if you are asked to mention about clinical features to identify the differential diagnosis or separate differential diagnosis, these are the questions we are supposed to ask. And depth of jaundice, or how deep the jaundice is, if it's yellow, green, or very dark, then of course it's mostly likely to be surgical jaundice rather than a medical jaundice. Hemolytic or hepatocellular jaundice is lighter in color. So sometimes it's so deep that even buccal mucosa and palms, it will be obvious. And then comes the episodic nature of it, episodic right hypochondrial pain. Why you are asking that? Episodic hypochondrial pain, dyspepsia, gallstones, that combination of questions, those are there, then we know that you are gunning for the diagnosis of gallstones. So bile duct stones are secondary to gallbladder stones. So this set of questions have to be there somewhere in your history. And recurrent fever with chills and rigors, recurrent episodes, again, whether these symptoms are there or not, these questions have to be asked directly. That indicates ascending cholangitis with septicemia. You know the famous Charcot's triad, where fever, jaundice, and abdominal pain is the combination. Then comes the recurrent epigastric pain radiating to the back. Is a recurrent pain and recurrent episodes. If you have asked this question, or if you mention it in the SCQ, we know that when you're writing the SCQ, actually you have to write this part and this part together. You have to say asking recurrent epigastric pain radiating to the back, which indicates acute on chronic pancreatitis. So like that, you give the interpretation also straight away. And even in a good history, if we are actually quite conversant and ready for the presentation of history, you can do the same thing. You can tell this symptom and then say that which indicates this disease. So that will prevent the examiner in between asking, why did you ask this, why did you ask that. So you say that recurrent epigastric pain radiating to the back, to entertain the possibility or to exclude the possibility of chronic pancreatitis with acute episodes. And associations such as stools, urine, and generalized pruritus, this set of questions have to be there. The clay colored stools are very standard from third year onwards, your training, because that shows that lack of bile salts and bile in the gut. But remember, know why exactly these things are coming. Because why do you get clay colored stools and dark tea colored urine? Because to our surprise, on and off we find somebody, when we ask, tell me why these stools are clay colored or gray colored, then occasional student might get stuck because he has forgotten his physiology. So just know these basic answers. And alcohol consumption is a must question, because alcoholic hepatitis has to be excluded, and also cirrhosis will not cause jaundice, only during its terminal phases, but alcohol is connected to chronic pancreatitis, though again the connection is controversial. These are an MCQ, so just remember, though alcohol directly causes chronic pancreatitis, acute pancreatitis, chronic pancreatitis, the connection is controversial. So they have not shown clearly the connection. In fact, some studies say that beverages like wine and beer can be protective in getting chronic pancreatitis. You're not quite sure how far that is true. Then comes the next point. The eighth point is a differential diagnosis of jaundice again. To exclude the differential diagnosis of polycytic jaundice and hepatitis C, you just you must look for these things actually. But then you can ask, because there are sometimes the tattoos are there in places where you might not see. So in a history, if you say that I ask for tattooing, history of dialysis, and repeated blood transfusions, we know that you are heading for the diagnosis of hepatitis. And the occupation is important because to exclude leptospirosis and paraquat poisoning. And the signs of advanced malignancy, again one or two questions like severe loss of weight, appetite, and severe anorexia will give us the examiner an idea that you are thinking of either gastric cancer with hepatitis nodes or liver secretaries. So these 10 questions, marking scheme, we will be looking for these 10 questions. As you already know, that rest of it is, all the other details carry very low marks because everybody says that. I mean, financial status and social status and the name and the story of the patient, they are all, everybody more or less, tackles that part well. But what the mark carrying part is these direct questions. Then move on to the examination, because the first examiner has the task of asking, listening to the history and asking a few questions, and then moving on to the examination. Then again, you have to give details about, always start with general examination. Jaundice will be an obvious, because in long cases, basic general examination points we look for anemia, jaundice, cyanosis, peripheral edema, lymphadenopathy, and such things. So out of that, so this is the case of jaundice, so you emphasize on jaundice. So just look for all these places to see the depth of jaundice. And then rest is, I think we will be waiting for you to give the abdominal findings. But always look for, in general examination, look for surface scratch marks, because in deep jaundice, there are scratch marks. There are obvious scratch marks. Your friend says that and you will not notice that. I think that will be not a great negative mark, but it will be a miss. So look for scratch marks. And then in the abdominal findings, and also look for the nutritional status of this patient, because as you know, these patients will end up in surgery. So always look for recent signs of emaciation and the nutritional status and the hydration. So in general examination, you have to mention those things. And abdominal examination, palpable gallbladder, carefully look for it. Generally, these patients are thin, and if there is a palpable gallbladder, that will be quite palpable and obvious. But specifically look for it. And palpable gallbladder itself, if you find that, it will lead to the discussion. It will lead the discussion towards more pancreatic cancers and other causes of palpable gallbladder in jaundice, which we will be discussing in a minute. Then looks for epigastric masses associated with jaundice again. Epigastric masses, generally a gastric cancer. Gastric cancer, how you connect gastric cancer to jaundice is that, again, porta-hepatis liver metastasis or porta-hepatis lymph nodes. So look for masses there. And then advanced pancreatic cancer, if it is palpable, of course, it is very advanced. and highly unlikely that you might get such case for the long case. But when you are discussing an CQ, always mention this fact. Look for epigastric masses for these reasons. And chronic pancreatitis, again, there are no epigastric masses in pancreatitis itself, but if you have a mass, it can be a chronic pseudocyst. So then palpable gallbladder, it could be a biliary stricture. We'll be discussing about Gaussian phenomenon. And then umbilical masses, just look for it, and very unlikely you will see anything, but you say that there are no umbilical masses. Examiner asks, for the sake of asking why you are looking for it, you say that again, metastatic spread of intra-abdominal malignancies, which again can be associated with jaundice. Moment you mention that there are no umbilical masses, the examiner will ask why. What is the connection? What are you looking for? So be ready with the answer. And hepatomegaly, invariably you have to look for it. Again, to exclude malignant causes of jaundice. Free fluid, you have to look for. And superficial migratory thrombophlebitis, Croce's sign. Again, a rare manifestation of pancreatic cancer. These are all plus points, distinction points. If you just mention it passing by, it will impress the examiner. You just look for it. And any questions in between, you can disturb me. It's all right, because it's always nice to have a discussion. Are you all hearing me?
Yes.
All right.
Yes, sir.
Not that all have fallen asleep, I suppose. Right. Okay. So that you will be moving on to the second examiner now. So by now you should have made up your mind, after going through this history and the examination findings. You should make up your mind. The history says that there is a history of gallstone disease, gallbladder disease, or the history is suggestive of a malignant process. Those two main things you have to make up your mind to mention. So keeping that in mind, the second examiner will ask, how would we investigate? Very standard. Always start, like any other long case, start with the basic investigations, like full blood count, and always be ready to interpret it. I mean, this is common to all long cases. Say full blood count, I'll be doing ordering a full blood count to check hemoglobin levels, because this patient might end up in surgery, because you can't directly connect hemoglobin levels to jaundice. So, and also always say that as pre-operative assessment. And yeah, I think this is a misprint. I think this pernicious anemia, there's no direct connection as such. And then urine, then the bile salts, urobilinogen. I think you should know a little bit about the physiology of jaundice, because this is not the time to go into details, but what is the physiological basis of hemolytic jaundice and obstructive jaundice and hepatic jaundice, parenchymal jaundice, or cholestatic jaundice, because occasionally there are some examiners who are really interested in their basic sciences. So suddenly they might ask a very basic question. So read around the physiology of jaundice. And serum bilirubin, direct or indirect, is a must. And then clotting profile for all practical purposes, it is important, because these patients are heading for surgery. So there's a bleeding tendency, and vitamin K deficiency caused by malabsorption of fat is a very basic thing we have taught you all. So know the factors which are affected. And renal function test is a must, all patients. So this is a basic set of tests. You should be prepared. Be prepared. As soon as they ask, keep on giving this standard set. Additional ones are actually in this particular case is the bilirubin levels. Liver function test again a must, and then chest X-ray and ECG uh, as a pre-op assessment, and plain X-ray of abdomen. If they ask what information are you going to gather, about 10% of gallstones are visible, and also porcelain gallbladders. That indicates chronic polycystitis, porcelain gallbladder, and then chronic pancreatitis. You might see pancreatic calcification and pancreatic stones. So just know a few things so that if somebody throws the question asking why do you want to do plain X-ray in a jaundice patient? So only 10% of stones are seen, remember that. And then ultrasound is very informative, so we have to mention that ultrasound. It demonstrates gallstones, presence of gallstones, and also recent or past infection. Thickened gallbladder wall indicates chronic polycystitis and having gallstones for a long time. And also it will show, the most important one is dilated common bile duct, because common bile duct dilatation is very important, and also intrahepatic duct dilatation. The common question we ask at this point is, what is the information we are going to gather in this patient by doing ultrasound? So know this list. Say that presence of gallstones, presence of gallbladder wall changes, and dilatation with mucosal formation. This is a rare phenomenon. Mirici syndrome is not that common. You all know what is Mirici syndrome. So mucosal formation and Mirici syndrome you can put down there, but duct dilatation, extrahepatic or intrahepatic duct dilatation is one of the most important information we are going to gather in jaundice, because if there is no extrahepatic duct dilatation, as you know, and intrahepatic duct dilatation, you know where the site of obstruction. So it is generally at the porta hepatis level or high up in the bile duct. So that is very important. And when will you call the extrahepatic duct is dilated? Any answers? When will you call the extrahepatic duct is dilated? What is the normal size of the common bile duct? Anybody? Size of the common bile duct?
7 centimeters.
Sorry?
2 centimeters.
2 centimeters. 2
7
centimeters or 2 millimeters? Yeah, it's over 1 centimeter.
diameter.
Okay. Uh, it's about 0.8 to 1 centimeter generally. But if it is over 1 centimeter, then there is, you call duct dilatation. Occasionally, some person might ask, when will you call it dilated? Okay. And for porta hepatis masses, liver deposits, all, even chronic pancreatitis done by a good ultrasoundologist in a thin patient might show tumors and changes in chronic pancreatitis, like pancreatic duct dilatations can be picked up in ultrasound. But always remember, ultrasound is not the best investigation for the pancreas, because it is covered by the bowel gas, duodenal and bowel gases. So know these facts about the ultrasound and jaundice, because it's a very commonly asked question. Information gathered in a jaundice patient by ultrasound. Then when it comes to the pinpointing the diagnosis or finding the exact diagnosis, contrast enhanced abdominal CT is the number one. and combined with the upper GI endoscopy. Because upper GI endoscopy is generally diagnostic and therapeutic both. So contrast enhanced abdominal CT with bowel contrast will show bile duct stones and chronic pancreatitis, pancreatic head cancers, gastric cancers with port epidermis. All these common differential diagnoses will be seen in this contrast enhanced CT. Upper GI endoscopy and ERCP, again very important. And ERCP, all of you would have seen by now, so you should know the practical points of it, because we might certainly put a question or two to find out whether you have gone to the endoscopy room. So OGD combined with ERCP, and it's always good to mention about endoscopic ultrasound, which is coming up very fast. All of you have seen endoscopy ultrasound being done. Has anybody seen? You all are familiar with endoscopic ultrasound, or? Yeah, this is an upcoming endoscopic investigation and even a therapeutic measure. So you should know about it. You don't have to know the details. I'm sure some of you all who have worked with GI surgeons might have seen this. And laparoscopic ultrasound, especially when you are writing an answer, what is the place of upper GI endoscopy in jaundice? These four things have to be mentioned. Generally, you all will stop at OGD and ERCP, but if you mention EUS and LUS, that is laparoscopic ultrasound, that will show that you know the whole spectrum. And these are a few pictures about endoscopic ultrasound. It is basically OGD with a ultrasound probe at the tip. So you can use it for diagnosis of pancreatic masses, and even you can use it for therapeutic purposes. We will mention it later. And the magnetic resonance, ARCP therapeutic procedures. If I ask, ERCP can be used to treat jaundice, you should be ready with these answers. Yes. Sphincterotomy in case of obstruction at the sphincter of OD and that level, you can do the sphincterotomy and remove the stone if there's a stone stuck there, and basket retrieval of gallstones, and you can stent it. If it's a malignant stricture, you can stent it temporarily or sometimes permanently, and you can see these diagrams will show those things. And I'm sure during your course of training you would have seen these things. I'm trying to summarize these. And what is the place of MRCP? MRCP is magnetic resonance. In case now ERCP is invasive. As you know, ERCP is invasive and it carries certain complications. And as a house officer or a medical officer, you might have to tackle those things on and off. And MRCP is the non-invasive replacement of ERCP. Magnetic resonance is not invasive. It's an investigation, and that will give a lot of information here. Actually, MRCP has almost replaced this ERCP and PTC in getting the details of the biliary tree. So it's just MCQ saying that magnetic resonance is superior to ERCP and PTC. That is true because it's non-invasive. Because PTC, as you know, percutaneous transhepatic cholangiography and endoscopic methods, all are invasive techniques. So MRCP gives similar images in jaundice or obstructive jaundice. So they are superseding, or they are being used more frequently now to replace ERCP and percutaneous transhepatic cholangiography. PTC is actually now getting rare investigation. Have you all seen PTC being done in any of the units where you have worked? Well, okay. It was an old technique where you do it under local anesthesia. You inject the dye into the dilated intrahepatic bile ducts through the liver. So sometimes you get bleeding and then bile leaks when you puncture it. It is done under image guidance if you all have not seen it, and that technique is the oldest, and it was later replaced by endoscopic retrograde cholangiopancreatography and this oral and IV cholecystography, which was there a long time ago to diagnose biliary disease, is now of historical importance. Okay, so just know, have some basic idea about these investigations, because the second examiner's part is to ask your basic knowledge about these investigations. So commonly asked questions, we'll just run through these. How would you prepare a jaundice patient for surgery? Outline briefly the physiological implications in preparing a severely jaundiced patient for surgery. These are various things. These questions can come in various guises. They can be sugared and they can be just covered with various words. But basically, we are asking, how are you going to prepare a jaundice patient? Sometimes there will be a small case scenario, and then you will say, what will you do as a house officer uh, to prepare this patient? Like that, So you should be able to identify what basic question is being asked, though it is not asked directly. Now see that the second part looks like very complicated. We outlined briefly the physiological implications. Don't get confused. Okay. How do you prepare? Are there any special preparations which comes to your mind? Can anybody answer?
Vitamin K.
Yeah, good. And it's always nice to know the dose. If you how much do you think you should give? Okay, it's all right. You can always refer back, because always when you become a house officer, what we expect you to do is just write the prescription. So these basic things, know the doses. Anything else? Now suppose this is a SEQ, uh, part of SEQ where 40 marks are carried. What will you write? So think like a house officer, think like a houseman, and then answer. Don't think too in a too complicated manner. I'll open up the panel, but
Nail by mouth.
good. Sorry. Yeah.
Keep patient nail by mouth.
Okay. Nil by mouth. Yes, it's a common everybody. So nil by mouth. You don't stop at that. Say for how long? 6 hours for solids and minimum 4 hours for fluids. Like that. Just add something, because you are writing an MCQ. So nil by mouth is a stem. It is just a point. If you are asked to outline, then you do that. How would you means you have to describe it a little bit. So add something to the tail end of the answer. And vitamin K, you will say vitamin K added to prevent something like that. I am giving you an example to prevent coagulopathy or something like that. Okay. Anything else? The point and the interpretation of it. So then that will make an SEQ answer. Any other special points? Okay, this is a very common question, so try to remember these lists, these lines. It's a very crowded one, but you can summarize it actually. Say always start by saying that we'll take informed consent after explaining all the pros and cons of operation. So that's a good starting point, because if you are asked preparation for any surgery, this first line is that shows that you are a safe houseman. Okay. And then liver function test is a must. You have to mention, as we mentioned earlier, liver function test, because to test whether the patient is in liver failure and in which child's grade, because the outcome of jaundice surgery depend heavily on this liver status. So you have to show that liver function test you are ordering because of that. Okay. If you are, rather than giving a list, add another few words for the importance of that investigation. That previous slide, the table will give you the interpretation. And full blood count, fasting blood will clear. This line always you mention and say that as a preoperative assessment. But then in that, this creatinine is, you can mention the creatinine and the eGFR as a separate line to say that these people are more prone to get renal failure after surgery. Okay, and then you can mention the last point there, hepatorenal syndrome. Coagulation profile, as one of you all mentioned, vitamin K should be given, and then put the route and the dose. IM vitamin K 10 milligrams daily until. Now this is the full line of answer. When you are answering, it will be very impressive if you tell at that. And when you are answering the MCQ also, this will carry more marks. Rather than just saying just coagulation profile, say you will give vitamin K for this particular purpose. And you will order a coagulation profile, which is a must, which includes PT, PPTK, and INR. And group and DT, don't ever forget, the main is going to be major surgery most of the time. If you say for which is major surgery to cure jaundice, group and DT for 2 units minimum. And dental care, these are all standard answers. Dental care, fasting, you have mentioned that. Steam inhalation, pre-medication, WHO checklist. This set, go through that over and over again, and somebody asks how you do prepare for major surgery, these are the answers. Okay. Don't think only about the specifics, because you can just write it down, because that will carry marks. And fluid resuscitation is important because some of these deeply jaundiced patients are very dehydrated, and that is one of the causes of dehydration, septicemia, and one of the causes of dehydration is cause of hepatorenal syndrome. So because of that, well-hydrated patient is important. So hydration and the bowel prep. Bowel prep is also important. And then catheterization to sort of monitor the urine output, because if he is not producing enough urine, there's a higher chance of again getting complicated. So these points, as a house officer, you should do, and then try to remember these. What are the complications you will be looking for after an ERCP? Because after doing an ERCP, it's like an OGD, but much more complicated, because you will be doing a therapeutic procedure where the sphincter is incised, or sometimes intubated, and contrast material is injected. So there is some sort of surgical procedure is also involved. So post-operatively, you will be the house officer who is looking after these, because these are common investigations, endoscopic investigations and therapeutic measures. So naturally, these questions can pop up. What complications will you be looking after an ERCP? Anybody would like to answer?
Perforation.
Yes, perforation.
Acute pancreatitis.
Yes. Hepatitis,
Hemorrhage.
hemorrhage. Yeah. Okay.
Cholangitis.
Yeah, ascending cholangitis. Yeah, this is the whole thing, that when you are doing the post-op round, these are things you will be looking for. Severe abdominal pain, because these things are the diagnoses, acute pancreatitis, duodenal perforation. But as a house officer, you will be actually looking for, so you will say in post-op round, I'll be looking for severe abdominal pain, distension and rigidity, which indicates, and then you give the diagnosis. Okay. So what are the complications when you say that? Always the presentation, you start by giving the presentation, because we expect you to look at the question as a house officer rather than just listing it. And because of that, you keep them nil orally on IV drip, prepared for emergency laparotomy at least within first 6 hours. So and always look for shock and monitor the vital parameters, because sometimes the bleeding can be serious, can cause melena and even hemorrhagic shock. Persistent jaundice is another point you might forget to mention, because these are done for jaundice, relieve jaundice, which is persistent jaundice caused by failed procedure, misplaced stents, and retained bile duct stones, and other missed causes of jaundice. So this is the standard answer we expect. Now, when it comes to the last part of the discussion, always a condition will be given. And even in SEQ, what will happen is there will be a short history, and then they will be asking for the differential diagnosis. And part of the question will be, suppose the diagnosis is this, how do you manage this patient? So to answer that, I'm just summarize these things in those tables, because generally there's hardly any time for you all to write details. Important thing is the width of the knowledge rather than the depth of the knowledge. So as an example, now if you take pancreatic cancer, now suppose the patient has pancreatic cancer and jaundice. So management of pancreatic cancer part, the question will say that what will you do initially, and then if suppose it is found to have a pancreatic cancer, how do you manage? Just outline the management. So this is the outline actually. So imagine if you miss one of these big parts, like to mention minimal invasive therapy or palliative care wholesale, and you mention only about surgical management, you might lose some marks. So that's why this summary of the management is important. So I don't want to go into exact details in these things because those are done during your training program, but this is a summary. Pancreatic cancer generally, if it is curable, if it is confined to the after staging, if it is confined to the pancreas, it is Whipple's operation. We did it in one of the earlier lectures also. So part of the stomach, that is the distal part of the conventional Whipple's is different from what we are doing now. Standard Whipple, the duodenum and the pancreatic head is gone, and then 3 anastomosis comes to the scene, as I have already mentioned: the bile duct, the stump of the stomach, and the pancreas. If the pancreas is completely removed, only if you do the head of the pancreas part is removed, pancreatic tail will be there to be attached. Just look at a diagram and try to remember what is Whipple's operation. Stomach to duodenum, bile duct to duodenum, and jejunum to jejunum. If it is a partial, only the head of the pancreas is gone, tail of the pancreas also will be there to be joined. So these are the triple anastomosis sites. And always mention that it can be done either laparoscopically or robotic assisted, which is coming up very fast, but not very many people do it. Only the laparoscopic trained people will do that. Still, the open surgery is pretty standard. And palliative care is much more important because most of the pancreatic cancers are incurable. So Whipple's surgery, it has gone beyond Whipple's surgery. Then of course palliative care is there. So mention endoscopic stenting to relieve jaundice. Jaundice is one of the most troublesome complications. So stenting and a palliative triple bypass can be done without removing the pancreas or duodenum. You can just bypass the obstructed areas from the cancer. You do the same bypass without removing it. And radiation is again useful in pancreatic cancer palliation. And chemotherapy, you don't have to remember again the regimes, but just know that radiation and chemotherapy are used in pancreatic cancer. These details very rarely might be asked at MCQs, but basically know what modalities are useful in which cancer. Then chronic pancreatitis, if the diagnosis is given as chronic pancreatitis, we have already discussed this, so I don't have to go into details in dyspepsia lecture. So this is again a summary of how to manage chronic pancreatitis. So I'll skip that one. And ultimately, most of the time, you will end up in this diagnosis, that is choledocholitis, because the diagnosis will be pinpointed towards that. It will be given as, patient who is known to have gallbladder stones and then now presenting with jaundice. You know the diagnosis is this. And management, the outline is that there are a number of options. If there's jaundice, you can do an open choledochotomy. Open surgery includes open choledochotomy. You make an open incision and you at the same time do the cholecystectomy, because that is the starting point of the gallstones. And then once we have opened the bile duct and relieved the obstruction or taken the stone out, there will be edema and leakage, which can be very detrimental. So you always introduce a T-tube. I'm sure most of you would have seen the T-tube. And remember, if it is sometimes in hospice, the T-tubes are kept on the table. So remember to identify that and mark it correctly. And you leave a T-tube. Another option is again do a choledochotomy. And then if the stone is badly stuck in the lower end and you can't take it, you just connect the proximal bile duct, the open bile duct, to the duodenum so that it can drain directly into the duodenum. That's open choledochotomy and choledochoduodenostomy. That's another option if the lower end pathology is really bad and you can't reach it. And these are open surgical options. And minimally invasive therapy is the preferred treatment nowadays for gallstones, bile duct stones. And ERCP and stone removal is the most commonly done surgical procedure. I'm sure some of you all would have watched this being done. What you can do is you remove the stone, which is, you can see this in this OGD, ERCP. The stone can be removed after doing a sphincterotomy or just retrieve it. And then later on you can combine it, or at the same setting some people do lap cholecystectomy, because always the idea is under one anesthesia, if the patient is fit, to finish off the production line of the gallstones, because he has other gallstones. Again, you have to go through the same thing otherwise. And
Hello, sir.
in a specialized centers, you can do a lap choledochotomy. Laparoscopy can be used for both choledochotomy and then T-tube plus cholecystectomy at the for the bellies at the same operation. So know these options just to outline them. Cholangiocarcinoma, again, which is again I think you have to know few things about it when it comes to MCQs. Very unlikely at an MBBS level you will be asked details about cholangiocarcinoma, but that is for malignant stricture part in the differential diagnosis, that is high up in the cards. So just have some basic idea about the sites of cholangiocarcinoma. As you know, it can be classified into according to the level you can classify it, and most proximal ones, which are at the hilum, are called Klatskin tumors. And sometimes this word, this Klatskin tumor, some examiners just wait for you to say. So just know about it. And then the distal cancers are there. And depending on the site, the treatment can be decided. Distal cancers, they behave. They are treated just like pancreatic cancers, because they are close to the pancreatic head. So a Whipple's operation is not done only for pancreatic cancers. Even distal cholangiocarcinomas, which are not spread, Whipple's operation is still a possibility for a distal one. And then modifications are there, Burgess. You don't have to know the details, but just know the fact that Whipple's is they are not only for pancreatic head cancers, it can be used for cholangiocarcinomas as well. And the proximal tumors, as you know, in the hilum, are very difficult to treat. Hemihepatectomy, sometimes you have to take part of the whole liver out, is the only treatment. And minimal invasive therapies are there when it comes to inoperable ones. ERCP with sphincterotomy and biliary stenting. And self-expandable metal stents are now becoming popular. SEMS, they are called. They are highly recommended to bypass the obstruction. And mostly, I think it will be palliative care by cholangiocarcinoma. The prognosis is not very good. So biliary stenting, photodynamic therapy, chemotherapy, and radiotherapy, they are all on the cards. Biliary benign strictures, you can have some basic idea about it. This classification is there called bismuth classification. Very unlikely they will expect you to mention that at MBBS level, but always to get impress the examiner, you can always say that if you say what other strictures you know, what do you know about the strictures, you say that those can be either benign or malignant. So malignant strictures are cholangiocarcinomas generally, and benign strictures are can be classified into bismuth classification depending on the site again. So when it comes to treatment, distal obstructions, sphincterotomy and endoscopic balloon dilatation, it's not a very reliable method because the effects are very temporary. And sometimes biliary nasobiliary tubes, I don't know how many have seen this. Sometimes you can introduce as a temporary measure biliary nasobiliary tube after doing the sphincterotomy. You can introduce these to the biliary system to drain it. Earlier, to relieve the jaundice temporarily at least till we do the permanent procedure, they have to do external biliary drainage. They drain the dilated biliary system, obstructed system from outside through the liver, which carries a fair bit of complications. And this nasobiliary tube is a temporary measure where ERCP can introduce a long tube into the dilated by biliary system and drain it temporarily until the permanent treatment is done. And ERCP treatment involves sphincterotomy and again SEMS, dilated the self-expandable metal stents, and those are all temporary and have to be removed. And this is again an MCQ, it can pop up. And operative treatment includes an endoscopic treatment has failed. What you have to do is, drain the dilated system into a piece of bowel. That's Roux-en-Y hepaticojejunostomy for very proximal strictures. And cholidocojejunostomy, if it is more distal, the part of the bile duct is still there, you can bring the jejunum to the bile duct and drain it. And intrahepatic cholangiojejunostomy is the topmost one, somewhat like this, bismuth 4. So just have some basic idea about what to do, because I don't think they will go into details at MBBS level. There are a few common questions again asked during discussion of jaundice patient. What is Charcot's triad? We have already told that. Just know it, keep it in your fingertips without hesitation. And what is Causius sign or Causius law or Causius phenomenon? Anybody knows it? I think everybody should know this. Causius law. It's not a law anymore.
A
Once was
palpable
we asked this.
gallbladder is hello. A palpable gallbladder is unlikely to be due to gallstones.
Right. So why did it drop from a level of law into a sign or a phenomenon?
it's not always
Yeah, there are exceptions,
allowed.
isn't it? Can you give me a couple of
Yes,
examples?
Miretti syndrome.
Yeah, Milici is one, which is a rare one, though it's the word sounds nice, like Miris. Uh, it's a rare thing. It's not very common phenomenon. Any other causes? Uh, Two stones at the same time. Let us open this cage. Yeah, this is the Causius syndrome, Causius sign, Causius sign. All names are there. But what you said was, the answer was right. What basically it says is that if the gallbladder is palpable and somebody is having jaundice, can't be gallstones, because gallstones will uh, why can't it be gallstones if the gallbladder is palpable? If,
In
yeah,
gallstones, the gallbladder
gallbladder
is
become,
fibrous.
yeah, and impalpable. So that is the law. But if you have two stones, one in the cystic duct and one in the common bile duct, the one can cause jaundice, the other one can cause mucocele formation. What is a mucocele? Mucocele is when a cystic duct stones block the cystic duct, and then what happens? The bile inside the gallbladder get absorbed. Biliary pigments and salts will get absorbed, and the gallbladder wall will secrete mucus, and the gallbladder will be filled with mucus. That is sometimes called white bile. White bile. It's a palpable gallbladder, but the contents are white. So that is called a mucocele. So if you have one stone in the cystic duct, other one in the distal common duct, you can have jaundice but still a palpable gallbladder due to gallstones. So that's an exception. Medici syndrome you already mentioned. That's right. Medici syndrome is where, what is Medici syndrome? The moment you say Medici syndrome, the examiner will jump and ask, what do you mean? What do you mean by Medici syndrome?
A
That is,
stone obstructing the
yeah,
cystic duct.
yeah,
A stone obstructing the cystic duct.
yeah. How does it cause jaundice? Medici syndrome is a cause for
Uh,
jaundice.
it There would be inflammation at the cystic duct and blocking the
Yes.
common hepatic duct.
Yeah. Actually, not the common hepatic duct. It's the right hepatic duct. What is getting involved is the right hepatic duct. So mostly there's a lot of periampullary fibrosis. Yes. So that is Medici syndrome, and gallstone in the palpable. Suppose gallstones are there in the gallbladder, but the obstruction may be something else. Okay. Outline the post-operative care of Whipple's operation. Whipple's operation again done by many GI surgeons and general surgeons. So they just want to check whether you all are safe house officers. So suddenly this question might come up in a CQ or a long case. So again, I will, because of the time constraints, we'll rush through this. It is periphery monitors. These points, just go through these slides again, which are available for you all. These are common to most of the major surgeries. These kind of extra major surgeries, people's operation, because it involves many systems. It involves biliary system, it involves the gut. So because of that, it's extra major surgery. So these are the basic things you have to look for in your post-op ward round. The question will come as, what will you look in during your post-op ward round after I have done a Whipple's and gone? So that is one way of asking. Or basically, we are expecting you to say these things: vital parameters, continued ill and IV fluids, prophylactic antibiotics, so on and so forth. So just go through this list once more, and then for any major surgery, be prepared to just rattle it off. Because this is what exactly you are going to do as house officers. This is what you are going to look for. Whipple's diet is, I think you don't have to know much about it, but because what you have to know is basically the pancreas is missing after Whipple's operation. So you have to avoid various food stuff just to compensate the absence of the pancreas. That's called Whipple's diet. Just know that there is a word called Whipple's diet. And also look for hemorrhage, look for complications during post-op ward rounds after. So some of them are specific for Whipple's operation, some of them are common ones like myocardial events. Hepatorenal failure is something you have to mention because after jaundice, especially people with jaundice, especially unrelieved jaundice, hepatorenal failure is quite common. Read about it. What are the postulated causes of hepatorenal failure? There's no one reason. Septicemia, dehydration, parenchymal injury to the kidney, those are all postulated causes. So this list, again, you don't have to memorize it, but this is common sense. Okay, so that brings us to an end of the summary of jaundice. Jaundice is a massive subject, but I think what is needed for your long cases and SCQs I have summarized, and also some MCQ points are there in this lecture. Somebody has sent me a WhatsApp. If you have 5 minutes or 10 minutes, I can just go through that. This is on the dyspepsia lecture. He or she has sent this question just being given to you all at one of the exams. I'm sure some of you all would have answered this question already. Are you familiar with this question? Basically, when you get a question like this, what you have to do is just somebody has started doing it, underline the important facts. Like it's a mother of 3 or 10 or 15, it doesn't matter much, but it points toward the parity, so that ultimate diagnosis might have some connection. But the age is important because it's 84, the discussion is going to be different. Okay, and then you have next thing you have to quickly, when you get this thing, you just underline it in the paper itself, unless it has been specifically asked not to destroy the paper, printed paper. And then sudden onset is another line you have to draw. Okay, and one day is a short duration one. Okay, and 4 episodes of vomiting. 4 or 6 doesn't make much of a difference, but what it says is recurrent vomiting. And he has anorexia, nausea, fever. So if this patient, you just imagine he has come to the casualty with these things or the surgical ward, and what is going through your mind first. So just jot it down in your rough paper. What's your first diagnosis? Okay, and similar episodes for about upper abdominal pain of less intensity resolved after you have past 3 months. So past 3 months have to be underlined. Similar episode you have to underline. So that will give you a basic picture. Whenever a clinical scenario is given, quickly underline these things. So if you all are already not familiar with this question, can one of you all answer the first part? It doesn't carry much mark, only 15 marks. So don't waste too much of time on that. Okay. Apart from gallbladder pathology. So that means by saying that this examiner who has said this question he knows that you all directly straight away diagnose a gallbladder pathology. So what is he asking from this first part? The list 3 other causes for this presentation. So basically what is he asking is gallbladder pathology is the likely diagnosis in this, but now when you say gallbladder pathology, so he excludes all the gallbladder causes. Okay, so what is he asking is non-gallbladder. Can anybody attempt it?
Perforated peptic ulcer disease,
Yes. Okay.
acute pancreatitis,
Hepatitis, yes.
and hepatitis.
Yeah, hepatitis, again, remember that you can mention it and I don't think they will cut marks, but think of Surgical causes, if it is medicine question, yes, hepatitis is up in the cards. Yeah. Let's move with the questions I have just lined up for you all. Yeah, peptic ulcer disease. Fever is uncommon. Now she says fever, so you have to think of perforated, if at all you have to say, if it's just pure peptic ulcer disease. I'm giving this because she gives a history. And remember, there is no explanations in this part of the question. It's just asking for a differential diagnosis. So you can say in one line, peptic ulcer disease with perforation. If not, just, the history if you take, it pinpoints towards more peptic ulcer. So I think fever is uncommon, it's just an uncomplicated one. So you can add to this with perforation. Okay. And then anything else? You said acute pancreatitis, you said. You are right. So again, now you have to think of the past history they have given. They have given as recurrent episodes and it has been going on for a long time. So you can say acute on chronic pancreatitis because you have to take into consideration the chronic part of it as well because it gives a history. It's not the... And then vomiting, again, you have to think of, now your third diagnosis was hepatitis. Yes, I don't think anybody will. And liver abscess is another possibility, amoebic or any other bacterial liver abscess. And chronic, this pyloric cancer with gastric outlet obstruction and GORD also has to be entertained at some stage. So if you write ulcer disease with perforation, acute on chronic pancreatitis, hepatitis or liver abscess, I think you have passed that part. And even these two have to be entertained. If somebody has written, the examiner would have put it as an additional mark. Not additional mark, additional point to be considered. And these things are not, people are not very dogmatic. They are not expecting you to write exactly what it is, but the common diagnosis are given, then you generally hit the full mark. But don't waste too much of time on that because it says list. Second part. So now this is the way one person might answer, but if it is something else, somebody else might say various other things. Now see, the second question is list 3 clinical features and 2 investigations for each condition you have mentioned in 1.1 in order to help differentiate from other causes. So I think you have to, here you are in a bit of a tight spot because we have to write something specific. Okay. So if you have written hepatitis, you write the answer according to that. Okay. And okay, now this is how I would do it. Say I've just short period I have just lined this up for you all. I think what you must write is this is kind of a fairly big question. Now you can see that there are so many lines you have to adapt. Clinical features, 3 clinical features for each. So you say chronic peptic ulcer disease with perforation. You have to write the clinical features which will differentiate it. But suppose if you are thinking of, if you say that there is acute abdominal pain, they are non-specific because peptic ulcer perforation and pancreatitis all will come in the same way. So question says how to differentiate from the other, from one from the other. So you have to think of something specific if you are writing. So I don't know exactly what is the marking scheme for this particular question. The person who makes it generally gives a marking scheme, but carefully going through the wordings, you have to think of something specific. Like now, I just give as an example, peptic ulcer disease, aggravation or relief by food, relief of pain after vomiting, succussion players. These are two in history and one in the investigation. So something like that. Pancreatitis, again, radiation to interscapular region, relieved by bending forwards, association with steatorrhea. So these are specific for these diseases. But if you write common clinical features, then of course that whole idea of asking that question that way is gone. And investigation again has to be something specific. If you write about peptic ulcer disease, barium meal or upper GI endoscopy. Now this says specific investigation should differentiate from the other. So if you say that it's perforated peptic ulcer disease, you may be right in this present situation, but you have to, in this part, you have to discuss that as the disease itself, not this presentation. Presentation may be just a result of the disease, but the question is pointed towards the whole disease. So peptic ulcer disease, you have to write these two because we have asked two investigations. And then pancreatitis, you can say serum amylase in acute episodes, and ERCP. And gastric cancer, I have put it as because recurrent vomiting and epigastric pain and waxing and waning symptoms, you will have to always think of a malignant cause. Try your best to think of a malignant cause. Maybe a perforated gastric cancer or penetrated gastric cancer, but pyloric cancer can be obstructive. So always think of a malignant part to show that you are thinking of malignancies as well. Endoscopic ultrasound. So this is how I would tackle that middle part, but there's more than one way to tackle this question. Third part, acute on chronic calculus. Now, what is the diagnosis? This is given as the findings. So now we already know by going through this that this is something to do with the gallbladder. So ultrasound scan shows thickened gallbladder with gallstones and pericholecystite because it's pericholecystic fluid. Those are classical signs of acute cholecystitis. And WBC, high blood WBC count is also supportive. And likely diagnosis, now you can give any part of this. You can say acute cholecystitis, acute on chronic cholecystitis, acute on chronic calculus cholecystitis, calculus bacterial cholecystitis. So if you give this whole line, you will get probably the full marks because there are 15 marks. For two words, giving 15 marks, I think is probably you will not get the full 15 marks. You might get 10 marks. So if this is the full answer, so give the full pathological diagnosis there because there is no other details they are asking in this question. See, what they are asking is basically what is the likely clinical diagnosis. But then again, you can now with these things, you can write the other things also. Apart from that one line, because there are 15 marks, you can say empyema of gallbladder, a perforated gallbladder, okay? And then those complications of cholecystitis also you can like emphysematous gallbladder. Even these three, if you write, you will get probably full marks because if you just say acute cholecystitis, you will get about 5, right? So you can include the other complications in this of cholecystitis, emphysematous cholecystitis, empyema, and gallbladder perforation. And briefly discuss the management of this patient. It carries a lot of marks here. So to finish this, you can go through this. It carries the maximum marks. So again, categorize any type of management if they ask. Immediate management, okay, 1.4 immediate management. Just imagine what you will do when patient comes with acute cholecystitis, which is a very common disease, and we expect you to know everything about it. So IV antibiotic, the Sanford guidelines, you have to know what exactly we are giving. So this is the generally advised one, but nowadays this a theory called de-escalation theory, where you start with, if the patient is septic, you start with the highest form of antibiotic. So the patient may be heading for surgery, so consent and all these standard things. And the vomiting has to be addressed with NG suction or antiemetics, and the analgesics for the pain. And conservative management, you must say that no, because this is the part of the question which we have to spend a lot of time. maximum amount of time. You can say that he can be managed conservatively only if these criteria are there. And then you have to move on by saying that as he has been having recurrent symptoms, cholecystectomy may be indicated or immediate exploration may be indicated if you are suspecting an acute abdomen. And when you write that part, then you have to write the preoperative care. Even if you write it in one line, it doesn't matter, because we'll be looking for these points wherever you write. You write it in point form or in line, doesn't matter. And you have to mention about the postoperative care as well. Time has run up now, so I think we'll probably discuss some of these long questions if you send it to me. I think it would be nice if we can discuss it. Towards the end of these lectures, we can discuss these long cases. Okay, so just go through these again and then try to absorb as much as you can. Are there any questions you would like to ask? So we have started a little late, but yeah. Okay, what you can do is you just send it WhatsApp to me or SMS to me, or are there any questions they have asked? Yeah. Okay. Okay, so somebody is saying that we should discuss more SCQs. Yes, we'll do that. What you can do is you can send me some SCQs from your past papers. I will also try to line up MCQs from each. Yeah. Somebody is asking questions about vascular surgery. Yeah. Ectovascular surgery. Which type of heparin is much more prevalent acute ischemia? Yeah, I think low molecular ultra. Yeah, I think low molecular weight and ultra uh, fractionated heparin. Uh, yeah, I think both are used, and acute limb ischemia. This is a question I think I have to probably verify. Uh, is this a question came up in a MCQ or something like that? Because these are used. Yeah, I'll get the answer next time. I'll go through it. I'm also not quite sure which is best, because to my knowledge, I think both are used. Uh, and then I'll find out if there's any particular reason for ultra fractionated one. And yeah, you all have been answering some questions which I didn't see actually. Good. The vascular surgery lecture will come up very soon, maybe the next one, and next one is vascular surgery discussion. So I'll try to get these answers. If you have any questions in vascular surgery, just post it to me, and I'll include that in the discussion. Okay, and it's a management of bowel perforation. Okay. Right. I will probably, what I will do is I will start by answering these questions at the next. This will be available. No? I'll line up these questions and start answering these questions, because you will be listening for last 1.5 hours. So I will line up these things and answer the questions. And next will be most probably vascular surgery discussion. And you can send any vascular surgery questions to me, and then I'll be ready with that. Okay then. So thank you for listening that, and